This patient is having traumatic cataract with 2 clock hour of zonular dialysis. After making the sidepod incisions, lignocaine with adrenaline was inserted inside the eye. I plan not to use the trypan blue dye because in cases of traumatic cataract with zonular dialysis, trypan blue dye tends to go behind the lens inside the vitreous and prevent the glow. Capsulorhexis was made using cystitome. You can see wrinkling of the capsule, suggesting area of zonular weakness. Rhexis was made in a way that it should be at the center of the lens. Hydrodissection was performed. As I am trying to rotate the nucleus, you can see 2 o'clock zonular dialysis at the infratemporal region. No more attempts of rotating the nucleus were made. After clearing the epinucleus, the nucleus was divided into 2 segments. As you can see, I could crack it in the front, but at the back part it was not cracked. It's difficult to rotate the nucleus, so I held it there itself and cracked it again. Now, without giving an attempt to rotate the nucleus, I chopped the nucleus then and there itself and emulsified. Now I could rotate the other half of the hemisphere and chopped and emulsified. Epinucleus was removed. Now, before removing the handpiece, I should have filled the AC with the viscoelastic to prevent vitreous prolapse. There was not much of the cortex, so I planned to insert the CTR before removing the cortical matter. Most of the cortex which is present is at the location of the zonular dialysis. Through the sidepod, I inserted the first eyelet of the CTR and directed it tangentially along the equator of the bag. Once I reached at the second eyelet, I held the eyelet with the forceps and transferred it to my Sinskey hook. We can either use Sinskey hook or micro forceps to hold the CTR eyelet and insert it inside the bag. Now you can see me doing sweeping movement with the dialer to look for any vitreous. Using Vanna's forceps, the vitreous strand was cut near the pupillary margin. Irrigation aspiration was performed to remove the cortical matter. Whenever we have to remove the cortical matter with CTR in place. It's always better to do the sweeping movement tangentially to loosen the cortical matter and then pull the cortical matter at the center of the eye to aspirate. And we should remove the cortical matter from the area of intact zonular support first, followed by area of zonular dialysis. IOL was inserted inside the bag with the haptics in the region of the zonular dialysis to further support the capsular bag. Viscoelastic was removed using bimanual technique, and I decided not to go behind the IOL because of zonular dialysis. Pilocarpine was inserted over the iris. Wounds were hydrated and eye was passed. Patient had good post-operative outcome of vision 6-9 on the first post-operative day. Thank you for watching.